Good evening, everyone. This is Dr. Veena Venkatesh from Ajanta Pharma Limited, working as a General Manager, Medical Services. On the behalf of Ajanta, I welcome all the delegates to today's webinar. Today's topic would be Repaglinide and Voglibose, a better option in PPG and diabetes management. Ajanta Pharma is one of the fastest growing pharma companies with a research orientation, and it's known for bringing first time in India formulation. Today we have with us for the program Dr. Rakesh Kumar Sahay. I have a privilege of introducing him to the audience. Sir is MD DM, fellowships like FACE, FICP, MAMS. He is the professor and head of the Department of Endocrinology, Osmania Medical College and Hospital, consultant endocrinologist, Sahay's Endocrine and Diabetes Center, Amirpet, Hyderabad. He's been the Vice President, Endocrine Society of India and South Asian Federation of Endocrine Society. He's been the Vice President of ALAA-RBO, Executive Committee Member of National RSSDI, former Secretary, Endocrine Society of India, Founder Secretary, South Asian Federation of Endocrine Society, former Chairman of the AP Chapter of RSSDI and Hyderabad Chapter of API, Associate Editor of Indian Journal of Endocrinology and Metabolism. Several awards to his credit. Fellowship of American College of Endocrinology in 2009, Fellowship in 2015, Fellowship of the Indian College of Physicians in 2006, First Senior Lectureship Oration of Association of Physicians of India in 2008. There are several publications to his credit, over 130 publications in various national and international journals, and he has authored several textbooks and the monographs on diabetes and endocrinology. With this brief introduction, I would like to call upon Dr. Rakesh Kumar Sahay for his talk. And our audience, please, if the questions should be put in the chat box. Once Sir's talk is over, then it will be taken up. Sir, over to you. I'll stop sharing the screen so you can share now.
Thank you, Dr. Veena, and thank you to Ajanta Pharma for arranging this webinar today. And good evening to all the participants who have spared their time today to join here and listen to what I'll be speaking. So what I will be doing is I'll be speaking about the importance of postprandial hyperglycemia, and then speak a little about the therapeutic aspects of postprandial hyperglycemia and the use of a fixed dose, a combination of Repaglinide and Voglibose, which has been recently launched. So I'll restrict my, I'll go about in that fashion. So So if we look at, we all know that we are going through this epidemic of diabetes. We're going to a pandemic of corona, plus we already have this growing burden of diabetes happening, and diabetes almost exploding with so many people being affected all over the world. And if you look at the highest numbers of people with diabetes, India ranks second, next only to China, and today we have almost 60 million or 70 odd million people with diabetes. We are going to have almost 140 million people in the next 20 years or so. So we need to be looking at getting better options to managing diabetes, or even options to prevent diabetes, and look at how we can overcome the burden of diabetes. So that's the major challenge that we have today. And what we see is that for the development of diabetes and for the progression of diabetes, postprandial hyperglycemia is a very important issue. So today we'll be focusing on the dark phase of postprandial hyperglycemia. Postprandial hyperglycemia, as we all know, is the excursion of glucose levels which happen after a meal, and typically we could measure it 2 hours after a meal. Traditionally, we measure it 2 hours after a meal, and a normal person is expected to have a postprandial glucose level less than 140, and it is said to be postprandial hyperglycemia if it is more than that. And if you look at the progression of diabetes or the onset of diabetes, if you look at the onset of diabetes also, probably this is the first abnormality to occur. Postprandial hyperglycemia is probably the earliest abnormality to occur in majority of our patients, and it is also the also the factor that causes the progression of diabetes. So we'll discuss about postprandial hyperglycemia, what is causing this, and what is the driving force behind this. Is it a genetic factor? Is it because of environmental factors, or is it because of both of them? So let us look at what is driving this epidemic of diabetes, and also today specifically we're looking at postprandial hyperglycemia. So if we look at our genetic factors, or genetically what happens to us as Asians, we are genetically different from the Western population. We see that we tend to have a higher glycemic response to common foods. I mean, if you look at the same foods, when they've given in this elegant study by Henry et al., what they did was that they gave the same foods to patients who were from Asian Indian origin, and then those who were Caucasians. And what they saw was that for the same type of food, we tended to have people with Asian origin tended to have a higher excursion of glucose levels. So as you can see, with the same type of food, the column on the right shows the mean levels in Asian Indians, and this is a small study, but this elegantly showed that probably we have a genetic inherently intrinsic sort of mechanism for having more of postprandial hyperglycemia. And if you look at the phenotype itself, phenotype of Indian diabetic, we know that we have onset of diabetes at a younger age. We already know that we have lower BMI, yet we are relatively more, we have more of visceral fat. We have lower BMI, but more of visceral fat, which is metabolically more active, which is causing all the problems, more of postprandial hyperglycemia. We have a more marked deficit in the first phase of insulin secretion, and this translates into higher postprandial glucose levels, and also higher IGT, also higher prevalence of IGT, and a rapid progression from IGT to diabetes also. And we have other mechanisms, probably specific gut microbiota, disturbance in the gut microbiota may also be contributing to that. And what we have seen is that this is what is the characteristic. We have some genetic factors which are contributing to that, but is it all genetics? But we also see that it's not always all genetics. It is also the type of food that we are consuming. So if you look at this chart, this is a study which we had conducted all across the country in 5 or 6 different centers across the country, and we found that the average carbohydrate intake across the country was to the tune of about 66-67%, and it was the same across the country. Whether you look at, we tend to think that South Indians probably have more of rice intake and they tend to eat more carbohydrates. It is less in other parts of the country. But what we saw was that whatever form of carbohydrate that is taken, carbohydrate intake itself is very high. It constitutes 64.1% of the total energy intake in the diet. Very little differences between different regions. And the postprandial glucose levels of 62.5% of diabetic patients were above 180 milligram per day. So in this START study, we found that across the country, the carbohydrate intake is very high. And the other point that was seen was that when the carbohydrate intake, when the energy intake was more than 60% of the energy intake was coming from carbohydrates, what we find is that there was a much higher glucose level, postprandial glucose level. As you can see here, the postprandial glucose level was 224 in people who were consuming more than 60% of energy in the form of carbohydrates. But at the same time, if you look at people who are consuming less than 60% of energy from in the form of carbohydrates, they tended to have a 20 milligram lower glucose levels, while the fasting glucose levels did not change much, as you can see here. So these were diabetic patients, but you can see that those who consumed higher proportion of carbohydrates in the diet tended to have higher postprandial glucose levels. So this is quite clear that it is not just genetics, but it is also the type of food that we are eating, and other environmental factors also are playing a role. And what we see is that if you look at the natural history of patients with diabetes, what we have a understanding from a lot of different studies is that what happens is that there's a long period of pre-diabetes, or long period of metabolic disturbances that antedate the diagnosis of diabetes for several years, maybe 6 years or 12 years. In different studies, we have got different data showing that for a long period of time there is the development of insulin resistance, which happens very early. Then the insulin secretion starts falling down. There is an alteration in the beta cell function. There is incretin abnormalities, incretin secretion, secretory abnormalities in the incretin factors. All these antedate the development of diabetes. And if you see, if you look at the development of diabetes itself, as you can see in this cartoon, you can see in the center, the line which shows the onset of diabetes. And if you follow the blue line, light blue line, which is the postprandial in the lower part, lower panel, if you see the light blue line, that's the postprandial glucose level. And if you see, that is the one which is rising first. So the postprandial glucose level is the first one to rise. And that rises even before the fasting glucose level rises. So that's what we see classically in people with diabetes, that postprandial glucose levels start rising early, and they are the ones which actually are driving the progression from pre-diabetes to diabetes, and also within diabetes also it is a very important component for the development of microvascular and macrovascular disease itself. So that's the reason why postprandial hyperglycemia is very important. And as you can see, if you look at the these pathophysiological abnormalities which are contributing towards glucose homeostasis and also contributing towards the progression of diabetes, what we see is that there is a, if you look at, you can probably divide it into three phases. You can say that the first one is the postprandial hyperglycemia. That's the earliest one which develops. This is followed by fasting hyperglycemia, and nocturnal hyperglycemia comes in later on. So as you can see, that postprandial hyperglycemia is very important. It contributes to a major part of the hyperglycemia during the day, and it is the one which starts off early. And a gradual loss in daytime postprandial glucose control precedes a stepwise deterioration in fasting plasma glucose level, a stepwise deterioration in the fasting plasma glucose, and with deteriorating diabetes. So this shows that the postprandial glucose abnormalities are probably the earlier ones, and they are the ones which are important and which have to be addressed adequately. And if you look at the time of the day spent by any person in the postprandial state, typically you can say you have three phases. One is the fasting phase, then you have a postprandial phase, which is the phase of say 2 hours or 2 to 3 hours after a meal, and then you have a phase of post-absorptive phase, which you can say constitutes about the time of about 4 hours after after the postprandial phase. So initially you have postprandial phase, then you have a post-absorptive phase which lasts for another 4 to 5 hours. So it is, if you look at these two components together, postprandial and post-absorptive phases, then we're seeing that most of the day is spent in these phases, and a very little time is spent by an individual in the fasting state. True fasting state is probably early in the morning or just before he gets up. That's the phase when he's truly in a fasting phase. So that is a very small component. So therefore, if you're trying to look at therapies which are addressing only the fasting glucose, then you're probably looking at a very small component. And postprandial therapies which address the postprandial glucose are probably the ones which address major part of the day. Now, if you look at this interesting study from Monier et al., this was published in 2003, and it's been very popular, and everybody's used this, and all of you would have seen it many times. This is showing the relationship between the HbA1c and the fasting glucose and the postprandial glucose. And what this shows is that when the HbA1c levels are very high, then the contribution of fasting plasma glucose is much more, is about 70% to the HbA1c level, and only 30% is contributed by the postprandial glucose. But as you come down, as you get this person down into control, what you find is that the postprandial glucose becomes a major part and a major contributor to the HbA1c. And when you come down to less than 7.5, probably 70% of the contribution to the HbA1c is from the postprandial glucose levels, and these need to be addressed if you want to bring down the HbA1c below 7.5. And therapies which are typically targeting only the fasting glucose may not be able to bring down the HbA1c below 7.5. So that's an important observation that was made by Monier et al. And this slide again goes to show the importance of that only, that it's the postprandial glucose and not the fasting glucose that distinguishes patients with HbA1c between 6 and 7. So that's how we are seeing that, as you can see in this picture, that what we are seeing is that the fasting glucose levels are almost similar between people who have got HbA1c between 6 to 6.5 in these two panels. and the right panel is 6.5 to 6.6 to 7. You can see that there's not much difference in their fasting glucose levels. But if you look at the postprandial glucose levels, if you look at the postprandial glucose in the next column, you find that there is a significant difference in that column. So this shows that if you're looking at HbA1c levels below 7%, it is mostly the postprandial glucose levels that determines how much the HbA1c is brought down or going up. So either way. So what we are seeing is now there have been further data on that, and this data from Wang et al. In 2011 actually showed something different. It shows a little difference in the sense that it says that even when you're looking at HbA1cs between 8 to 12, as you can see, the individuals who were included in this study were put into 5 quintiles of their HbA1c levels, starting from these are people with less than 7.1, 7.1 to 7.5, 7.6 to 8, 8 to 8.7, 8.3, and then 8.2, 8.7, and 8.8 to 12.7. So if you look at these 5 quintiles, what you can see is that even in this quintile, or this one also, where the HbA1c is more than 8%, here also what we are seeing is that postprandial glucose is contributing significantly, almost as much as the fasting. So their contributions are almost similar even here. And here the postprandial glucose becomes very important, whereas here also it is contributing equally. So that's the importance of postprandial hyperglycemia that is being seen. And particularly this study is particularly important because this had more of Asians involved in this study, and that's why we say that in our population, probably it is more of the postprandial glucose which is very important than the fasting hyperglycemia. So this is again going on to show the same factor. So what we have already said is that the postprandial hyperglycemia antecedes the fasting hyperglycemia, and it is the driving force for the progression from pre-diabetes to diabetes, and also in terms of the development of the complications. So having understood the importance of postprandial hyperglycemia, how it is contributing towards the onset of diabetes and how much it is contributing towards the towards the HbA1c levels, and at what levels of HbA1c it is important. Having looked at all that, let us now look at what are all the associations of this raised postprandial glucose levels in patients with type 2 diabetes. So what they have, people with type 2 diabetes who have postprandial hyperglycemia have a inappropriate sort of lack of appropriate suppression of the endogenous glucose release. So they have higher gluconeogenesis and glucogenolysis happening. So the liver is also producing excess glucose. The glucose which is coming in from the GI tract is not getting absorbed into the peripheral tissues. So there is both of these are contributing towards the increase in the glucose levels in the blood. Now, what does this mean? What does this mean for the individual? So postprandial hyperglycemia is very important. We have seen that it is common. It is seen as an early defect in patients with diabetes. But what does it lead to? It is an independent risk factor for cardiovascular disease. It has been shown in several studies to be an independent risk factor for cardiovascular disease. I'll show you data on that from different studies. It increases, and we have already discussed that this is the one which increases earlier and than the fasting plasma glucose levels. It contributes more to HbA1c than to fasting glucose at HbA1c levels below 8.5. Even above that, we have just seen some data showing that it contributes there also. And it's a rate limiting factor for achieving the adequate glycemic control. So this is something which has to be kept in mind, because then we need to look at using therapies which can address the postprandial hyperglycemia. And the other important thing is that it has harmful acute effects, causing endothelial dysfunction, increase in oxidative stress, increases the inflammatory milieu, and increases the protein glycosylation. And it also affects the coagulation pathway. So through all these mechanisms, these are the mechanisms which all contribute towards the development of the diabetic complications, in the acute setting and also in the long run. These abnormalities are contributing towards the development of all the complications of diabetes, and postprandial hyperglycemia is aggravating all these problems. That is, it is increasing the oxidative stress, it is increasing endothelial dysfunction, and as you can see here, a spike in postprandial glucose levels, when it happens, it strongly increases the oxidative stress. So this slide shows the correlation between the urinary 8-isoprostane. That is That's a marker of inflammation, marker of oxidative stress. And if you look at it, correlates very well, or correlates linearly with the MAGE. MAGE is the mean amplitude of glycemic excursion. That's a parameter that is done by frequently looking at the glucose levels. Either you can do by SMPG, or you can even look at the CGM data and calculate the MAGE. And that MAGE correlates very well with the oxidative damage that is happening, oxidative stress that is being generated in the tissues. Now, this study is showing us that if you're looking at the individual determinants of coronary artery disease, individual risk factors for coronary artery disease, whether you look at smoking, male sex, hyperlipidemia, hypertension, the MAGE itself, then HSCRP, age more than 65, renal insufficiency, so all these are plotted. And when you're trying to see the relationship between these and the contribution of each of these factors towards the development of cardiovascular disease, you can see that the MAGE becomes a very important factor. If you look at diabetes, or if you look at the HbA1c alone, it may not be as important as the MAGE is seen here. So showing that glycemic excursion is an independent risk factor for the development of cardiovascular disease. And repeated episodes of postprandial hyperglycemia are now considered to have greater pathophysiological effects on the cardiovascular system than persistent hyperglycemia. So fluctuating glucose levels with exertions happening in between are damaging to the vessel wall, damaging towards all the tissues by inducing oxidative damage. So let us look at some of the data showing the correlation between postprandial hyperglycemia and the morbidity and mortality because of diabetes. So what we have is that we have a meta-analysis of all these several studies which have looked at postprandial hyperglycemia correlation with the cardiovascular disease particularly, and they are all grouped together as a DECODE-R study. So postprandial hyperglycemia in that study has been shown to be, in that meta-analysis, has been shown to be a risk factor for cardiovascular complications in people with diabetes. So as you can see here, the upper panel shows the relationship between fasting glucose levels and the in various studies, and the development and the mortality in those studies, cardiovascular mortality, versus the postprandial hyperglycemia in the lower panel. So in the lower part, you see that the levels are higher. So the relative risk is 1.29, means a 30% higher risk of cardiovascular mortality because of postprandial hyperglycemia as compared to a 14% increase in risk by fasting hyperglycemia, showing the importance of postprandial hyperglycemia being a more important factor for the development of cardiovascular disease. And this is for CV mortality. So that the earlier slide was all-cause mortality. Here it was CVD mortality. So the CVD mortality with postprandial hyperglycemia increases about 35%. And with fasting hyperglycemia, it increases about 24%. All-cause mortality, as we saw in the earlier slide, it was the all-cause mortality. So this shows the importance of postprandial hyperglycemia in contributing towards the cardiovascular mortality particularly, and also towards the all-cause mortality. So 2-hour plasma glucose levels following 75 gram OGTT better predicted all-cause mortality and cardiovascular deaths than fasting plasma glucose levels. And mind you, all these studies, most of these studies, if not all, most of the studies were on non-diabetic individuals, saying that even in non-diabetic individuals, if they have a higher plasma glucose excursion following a 75 gram glucose load, they tend to have higher risk of cardiovascular disease even before diabetes develops. And then there are several more studies, several more epidemiological studies. I'll just mention the names here: Chicago Heart Association, and then the Diabetes Intervention Study. There's also a Russian study, Temelko Khrushchev study, and then the companion postprandial hyperglycemia study. All of them have shown the importance of postprandial hyperglycemia on affecting the cardiovascular morbidity and mortality, and also some of them looked at the surrogate markers like carotid intima media thickness. And so that's why we have seen that all these studies tell us that postprandial hyperglycemia is important. But does treatment of postprandial hyperglycemia, is it necessary, is the question that comes up. Because even though we find in medicine that many the associations may be seen, but by treating that you may not get the benefit. But let us see if treating postprandial hyperglycemia is going to give us a benefit? Yes, let us look at the factors that we are looking at. So the postprandial hyperglycemia is a better predictor of glycemic control than the fasting plasma glucose. I'll show you some data to support that. Then postprandial hyperglycemia is associated with microvascular complications also. Apart from the macrovascular disease, we saw all these large epidemiological data which have clearly shown that macrovascular disease was increased because of postprandial hyperglycemia. But there are some studies which have also shown that the microvascular disease also increased because of postprandial hyperglycemia. And the other important thing is it's become a recognized risk factor for CAD, MI, and death. So now let us look at this interesting study, which looked at how many people are achieving glycemic control if their postprandial glucose goal is achieved, and how many of them are reaching their HbA1c target if their fasting goal is achieved. So when you looked at that, when you compared people who are reaching a goal of who are reaching their fasting goals versus those who are reaching their postprandial goals, it was seen that if you look at just those people who are reaching their fasting target of say less than 120 or less than 100, only 64% of them reach the HbA1c target of less than 7. But when you look at the number of people who achieved their postprandial glucose target, if you're looking at a target of less than 140 as the postprandial glucose target, and if you look at the number of people who achieved this target, then 94% of them achieved the HbA1c target of less than 7. So this means that if you target the postprandial glucose levels, achieve a good control of the postprandial glucose, most of these patients who achieve a postprandial glucose control will reach the HbA1c target of less than 7. And we know that HbA1c 7 is a decent target for most of our people. You may have more stringent targets in a few patients, but most of our patients we look at HbA1c as less than 7. So what is a target that we should look at? So different organizations, what did different organizations say? Different organizations have given different targets for postprandial glucose control. Like if you look at the ADA has looked at a target, has suggested a target of 180 as a good postprandial glucose target. Whereas if you look at the AACE, the American Association of Clinical Endocrinologists, or the IDF, or even if you look at the RSSDI targets, you're looking at a less than 140 as a target for good postprandial glucose control. So 140 may be the target suggested by many organizations. Some organizations even suggest that less than 180 is good enough. So we need to look at how much we can achieve. If we are able to achieve 140 without causing hypoglycemia, probably that may be more better than reaching a target of less than 180. But that is at least that is what we need to look at. So what are the agents that can be used to address postprandial hyperglycemia? We have the glinides, we have alpha glucosidase inhibitors, we have prandial insulins, we have GLP-1 analogs, we have DPP-4 inhibitors. So we have a whole plethora of agents available today for postprandial hyperglycemia management. And today what we'll do is that we can speak on each of these for a long time, but in the short time that we have, another 10-15 minutes that I'm going to speak, what I'll do is I'll try to speak on the glinides and alpha glucosidase inhibitors, because our focus is on these two today, because we are trying to bring out the advantages of this and how this combination of this can be a good option for managing postprandial hyperglycemia is what I want to show today in the next 10 minutes or so, next 5 to 10 minutes that I may be speaking for more. So if you look at the benefits of Voglibose, if you look at Voglibose itself, we know that it's an alpha glucosidase inhibitor. The alpha glucosidase enzyme on the brush border of the intestine is inhibited by this, and it inhibits the breakdown of the disaccharides to monosaccharides, and thereby delays the absorption of glucose to a more terminal part of the intestine. And because of that, what happens is that there is a flattening of the postprandial peak. So it offers significant reduction in the postprandial glucose levels. The inhibitory activity of Voglibose on maltose and sucrose is much higher, almost about 250 times higher than that of acarbose, and it is 100 times higher than that of miglitol. It offers 34% reduction in the new cases of hypertension also, and it offers a 49% reduction in the new cases of CVD. So those patients who have diabetes with postprandial hyperglycemia who are being managed with this, they have lesser onset of hypertension, lesser development of cardiovascular disease, as you can see, from the studies that have involved the use of Voglibose. And this is an interesting study which had compared the three agents, 90 patients randomized to either Voglibose, Ecaribose, or Miglitol. And these are all patients with type 2 diabetes with postprandial hyperglycemia. And what was seen was that all of these alpha glucosidase inhibitors, as we know, have GI tolerability issues. They cause abdominal discomfort. They may cause a little bloating sensation. All these problems are there. And if you look at the tolerability profile or adverse effect profile, it was probably the least with Voglibose, and then with 16% with Acaribose and 33% with Miglitol. But one thing about this is that most of these adverse effects which you speak of, starts getting better if you start with a small dose and gradually uptitrate that, because there is activation of this enzyme in the lower part of the intestine also. So what happens is that this problem, which is seen often once we start the alpha glucoside inhibitors, starts getting better as they are able to tolerate it better over the period of time. And if you compare the effects on HbA1c reduction, as you can see, the reduction brought about by Voglibose is shown on the left panel, reduction in HbA1c. Then you can see the effect on the postprandial glucose level, which is quite significant. Even on the fasting glucose, there was some improvement in the fasting glucose levels. So this study therefore recommends the use of Voglibose as a preferential choice in the management of postprandial hyperglycemia in patients with type 2 diabetes. Then there was one study in Japanese study, which looked at following up individuals with pre-diabetes and randomizing them to Voglibose versus placebo. So 1,700 patients in this study, 800 or almost 900 patients received Voglibose, another 900 patients received placebo, and the subjects treated with Voglibose had a significantly lower risk for progression to type 2 diabetes than placebo. So something in the fashion of the stop NIDD trial, which was with Acaribose, and significantly more subjects in the Voglibose group achieved normoglycemia compared with those in the placebo group. So this was published in 2009 in the Lancet. And there's another study which looked at the Indian patients with pre-diabetes, but this was a cross-sectional specialty survey, that is, looked at only asking the healthcare professionals what they felt about the impact of Voglibose in terms of preventing diabetes and in terms of controlling postprandial hyperglycemia. And what was seen was that across the board, all the people involved in the management of diabetes, whether you look at general practitioners, diabetes specialists, other specialists, all of them agreed that Voglibose is a important agent which can be useful in managing postprandial hyperglycemia. It can be effective in preventing the conversion of pre-diabetes to diabetes. So this was what the opinion was of all the people involved in, all the healthcare workers involved in healthcare professionals involved in the management of diabetes. Now, having looked at Voglibose, now let us also look at this other molecule, that is Repaglinide. Repaglinide, there's been a renewed interest now with Repaglinide. Repaglinide was introduced way back in 2000, but it did not become very popular. But now we are looking at more and more therapies towards postprandial hyperglycemia. Repaglinide also has been, I'll review some of the data available on Repaglinide. And as you can see, this was a study which was looking at comparison of Repaglinide versus glimepiride on insulin secretion and the postprandial hyperglycemia in patients with type 2 diabetes. So this was a 3-month randomized crossover parallel group trial of Repaglinide versus glimepiride in 14 patients who were with type 2 diabetes, were not taking any other treatment. So they were drug naive patients with type 2 diabetes who were given sort of crossover, initially Repaglinide, then glimepiride, and those who received glimepiride initially got Repaglinide later. So this way there was a crossover, and this was a study which was done with a clamp, hyperglycemic clamp, to study the insulin secretion. And as you can see from these two panels, it's a little complicated study which will not go into too many details of that. But what I will try to show you is in this study is that a hyperglycemic clamp is done to study the insulin secretion in any individual, whereas you do a euglycemic clamp where you're clamping the glucose levels at a particular level of 100 milligrams, and and you're trying to see how much glucose is going to be given to the person to keep the glucose level at that level, and that shows us how much of insulin resistance the person has. Whereas this hyperglycemic clamp actually gives us a good idea about the insulin secretion. So this clamp which was done in this study was a hyperglycemic clamp, and that tried to look at what was the difference between glimepiride and repaglinide in terms of insulin secretion. And this study showed that in the bottom panel, if you see, lower panel, if you see, you can see that the dark circles are the repaglinide, and the light circles are the glimepiride. So the increase in insulin secretion that happened with repaglinide was probably better than that which happened with the glimepiride. So this study which was published in Diabetes Metabolism in 2004 showed us that the CAMP technique showed that the insulin secretion was better with repaglinide. And then in the same study, when you look at the glucose and insulin levels in the plasma, what we find is that that with the repaglinide, as you can see in the lower panel again, the insulin levels peaked a little earlier than what it happened with the glimepiride. Almost the peak may not be very different. Peak did not appear to be very different, but the peak happened a little earlier with repaglinide. And similarly, the glucose levels rose to a little lesser extent with with the repaglinide as compared to glimepiride. So showing that it works fast, it works faster than glimepiride. It causes insulin secretion earlier, and insulin secretion also is to a slightly higher extent when it causes the insulin secretion, and that translates towards lower postprandial glucose levels. And there was another study done in Japanese patients with 10 patients with type 2 diabetes who were on glimepiride monotherapy were enrolled. After observation period of 8 weeks, this glimepiride was changed to repaglinide for another 12 weeks, and the endpoints were changed in the MAGE, the PI1 levels. PI1 is the inflammatory marker, as we know, and the urinary 8-hydroxyprostane and HSCRP levels. These are again inflammatory markers, oxidative stress and inflammation as can be measured by these markers. So this was what was measured in this 10 patients who were initially on glimepiride, and they had a CGM study done, and then they were shifted to repaglinide, and the CGM study was done again after 12 weeks of using repaglinide. So as you can see, if a superimposition of the studies done with repaglinide versus glimepiride are shown here. The dark one is the repaglinide. The lighter one, shaded one, is the glimepiride when the patient was on glimepiride. So as you can see, there was some improvement in the glycemic profile of these individuals. Lower postprandial peaking happening with the repaglinide as compared to glimepiride, and the glucose fluctuations also, when calculated, the MAGE was calculated, was coming out to be better with repaglinide. As you can see here, the glucose fluctuations in terms of the MAGE was lower with the repaglinide as compared to glimepiride. Glimepiride had higher MAGE. And when the other components were studied, as we just mentioned, that we had in this study, the HSCRP levels were compared, the urinary 8-hydroxyprostane levels were measured, and then the PI1 levels were measured. So all of them showed that there was lower oxidative stress and inflammatory markers being elevated to a lesser extent with the repaglinide as compared to glimepiride. So let us now look at, so having seen these few studies which have looked at both Voglibose and repaglinide, let us look at a fixed dose combination of these two, because they are working through different mechanisms of action. The Voglibose is working through reducing the slowing down the GI absorption of glucose, and repaglinide is acting by increasing the insulin secretion. So they can complement with each other very well, and a combination of that may actually be more beneficial for control of postprandial hyperglycemia than each of them individually. So this was an open label, non-comparative, single center study with 20 patients with type 2 diabetes from India. Fixed dose combination of Voglibose 0.3 mg plus repaglinide 0.5 or 1 mg 3 times a day was given for 30 days. The endpoint was a change in the fasting plasma glucose and postprandial glucose levels. And you can see that in this study, you can see these graphs that after 30 days of use of this combination, the fasting plasma glucose levels came down from 183 to 140, and the postprandial glucose levels came down from 267 to 206, showing that this FDC offers significant reduction in both the fasting and postprandial glucose levels. There was no adverse effect, including there was no hypoglycemia, reported in the study, therefore it appears to be an effective and safe option for management of postprandial hyperglycemia in Indian patients. So this is another small study which was done with this FDC, again fixed dose combination of Repaglinide and Voglibose, and patients who were patients with 0.25 to 1 milligram of glimepiride were enrolled and were switched from glimepiride to a combination of Repaglinide and Voglibose for 3 months. The endpoint again was a change in the MAGE and changes in the endothelial function by flow mediated dilatation. So this is another type of marker which is used to understand the endothelial dysfunction. We have looked at the inflammatory markers, we have looked at the CRP levels, we have looked at the oxidative stress marker, and we have looked at also now this is the endothelial function marker of endothelial function. As you can see in this study, there was a improvement in the flow mediated dilatation. Here the flow mediated dilatation improved. That means that in response to this flow mediated dilatation which happens when you tie the BB cuff and then release it, there should be a secretion of nitric oxide, and the flow mediated dilatation should happen to a greater extent. So that doesn't happen in people with diabetes, and that gets sort of suppressed in people with diabetes, and this was improved to a better extent with the combination of glimepiride, this Repaglinide and Voglibose as compared to glimepiride. Now, this is the postprandial and the fasting FMD, and you can see that there was improvement in this, significant improvement with this combination. Now, let us look at the safety parameters and look at whether this molecule, how it works, how it fares in people with renal dysfunction, because we know that many of our patients with diabetes have renal dysfunction, and postprandial hyperglycemia becomes a more important problem in renal dysfunction than in others, because the people with renal dysfunction tend to have a lower fasting glucose levels, but their postprandial glucose levels are very high. So this combination was used in a large number of patients. This study had almost 280 patients with 150 of them having normal renal function and 130 patients with various degrees of renal impairment. And here this combination of Repaglinide and Voglibose was used, or rather this was a study which used only Repaglinide up to a maximal dose of 4 mg 3 times a day. And what was seen was in this study was that Repaglinide worked well even in patients with mild to moderate renal insufficiency, and it had a good safety profile and efficacy profile in patients with type 2 diabetes who are complicated by renal impairment, and is an appropriate treatment choice even for individuals with more severe degrees of renal impairment. So this shows that Repaglinide, one of the components of this FDC, is a very good molecule for people with renal dysfunction, mild to moderate renal dysfunction, and it can control the postprandial hyperglycemia very well. And if you look at the pharmacokinetics of these two agents, you can see that that the Tmax of Voglibose is 1 to 1.5 hours. Repaglinide again is 1 hour. So it has to be given with each meal. As you can see, that even Repaglinide has a very short duration of action. It has high plasma protein binding, but it has got a short half-life, and it is not affected by food has an effect, and therefore it has to be given just before food is the best time, or just when the patient is going to start having his meal. This is the best time to give this combination, because it's going to work well, and it is going to have a short period of action, and it has to be given with each meal. And if you look at the adverse effects, we know that Voglibose has some issues with, can have, because of the mechanism by which it's working, it is going to cause gastrointestinal adverse effects such as bloating sensation, diarrhea, abdominal pain, and constipation, anorexia, nausea, vomiting in some of them, and even heartburn in some patients. But these side effects generally get better and better as the patient starts using a small dose and gradually goes up on the dose. Repaglinides, on the other hand, can cause mild to moderate hypoglycemia, nausea, constipation, dyspepsia may occur in a few patients. And the contraindications are probably only in patients with diabetic ketoacidosis or very severely ill diabetic patients should not be given this molecule. Gastrointestinal obstruction is another issue is a situation where we should avoid using this, or if somebody has got hypersensitivity to these agents. So these are the situations where it should not be used. And finally, I'll conclude by giving the salient features of what I spoke in this talk, that this combination, fixed dose combination of Repaglinide and Voglibose offers significant reduction in fasting plasma glucose and postprandial plasma glucose levels. Safety and efficacy is established in Indian patients. It improves the glycemic variability and endothelial dysfunction. No hypoglycemia is reported, thus, but it has got a good adherence, negligible chances of weight gain, and it reduces, and it is useful even in patients with mild to moderate renal impairment or hepatic impairment. And we are hopeful that it has got a very a good effect on the CVD and hypertension, because we have data from small studies showing that, but we expect that it will have a good effect on the cardiovascular outcomes also. Thank you all for the patient hearing.
Thank you very much, sir, for an excellent talk. You have covered very well and the importance of especially the postprandial hyperglycemia and the management of diabetes. It came out very well. Sir, there are some questions. Can I ask some relevant questions which are there in the chat box? Yeah. Sir, the question from Dr. Chinmaya. Can we use it for a longer period in CKD patients? He's talking about the combination. Can we use this combination for a longer period? Means how long can we use in CKD patients?
So actually, basically what we are saying is that Repaglinide is a short-acting agent, doesn't cause much of hypoglycemia. It works particularly in the for about, it has to be given before each meal, and probably amongst all the secretagogues that we know, Repaglinide is probably the safest secretagogue that can be used in patients with renal insufficiency, and you can use it even up to moderate renal insufficiency. I would say you can safely use up to a GFR of 30. You can safely use, with a little caution about hypoglycemia, that it doesn't cause hypoglycemia. You can use, I mean, that you're watching for hypoglycemia and any of the GI side effects. You can use it up to even up to what 15 ml GFR. That is when patients generally go on to dialysis. So till that extent, we can easily use this molecule, and because of this, because of the special advantages that it has.
Sir, another question from Dr. Prakash. We have a less Indian trial on Repaglinide. How can we go forward with this combination?
Less
Indian trial, Indian data.
Yeah. The number of trials available is much lesser than the newer molecules. I mean, you may have more number of patients having been studied, because this was introduced in 2000s. Then the number of patients who were included in trials were smaller trials. But now actually we have got the experience of using this for the last 20 years, and we have real world experience of using these molecules. So I think that's the more important part, and we should look at getting more information by analyzing our own patients who have been using these molecules.
So, question from Dr. Sanjeev Banik. What about metformin plus postprandial hyperglycemia? What about long-term safety of Voglibose plus Repaglinide in elderly population?
Yeah, elderly population is another group where this combination is expected to work well. So we know that elderly patients have several changes in their metabolism. The pharmacokinetics of drugs changes. A lot of drug interactions are an issue. So in this situation also, this combination works very well. This combination of Repaglinide Voglibose works well. And if you compare with metformin, and as you discussed about metformin and pioglitazone, probably they are very good agents for controlling the fasting hyperglycemia, but they are not very good for controlling the postprandial hyperglycemia. They will also control the postprandial to some extent, but if you're looking at particularly addressing the postprandial glucose levels, I think they are typically going to address the fasting glucose levels, because they are both working on the liver and the adipose tissue. Glitazones work on the adipose tissue, and they are particularly useful for fasting hyperglycemia. The DPP, on the other hand, the other newer agents like DPP4 inhibitors, GLP-1 analogs are better for the postprandial hyperglycemia.
So again, a question from Dr. Sanjeev. Is pancreatitis a contraindication for this combination? And what about CV safety?
Yeah.
We
So
mentioned.
basically, if you're looking at pancreatitis, pancreatitis is a situation where you would not like to use any of the secretagogues, because repaglinide is again going to work on the pancreatic beta cells, increase insulin secretion. So we don't want to use agents which are going to do that. We may not use them. Sulfonylurea is also not preferred in patients who have pancreatitis, and even repaglinide again becomes a non-preferred agent. And the second thing is that if they have problems because of the enzyme deficiency, pancreatic enzyme deficiencies, the exocrine deficiencies, then Voglibose will also be a difficult molecule to be tolerated in such situations. So pancreatitis is not a situation where we use this combination.
The, the question is, can this be given as a monotherapy, Dr. Ramesh?
Monotherapy with which one? Monotherapy with,
In patients, maybe probably the
yeah,
diagnosed patients.
monotherapy, we are speaking of single agents. We are here having a fixed dose combination. So the question of monotherapy doesn't come, but the question can come whether it can be used as a
This
initial,
FDC, maybe
initial,
only one, only this FDC can be used.
yeah, only this FDC as a initial therapy is what the question is.
Yes, yes, yes.
As a initiating therapy. Yes, you can use it in some patients like the group of patients that were used in pre-diabetes. It was used. Voglibose was used in pre-diabetes, and it was shown to prevent the progression from pre-diabetes to diabetes. So that was the scenario where Voglibose was used, and and Repaglinide also may work well in that situation. But metformin becomes a very good choice there. So metformin Voglibose is a very good first line choice. So this is a Repaglinide Voglibose is mostly addressing the postprandial hyperglycemia, and so it's particularly useful for patients having postprandial hyperglycemia, and this is after metformin. After you use metformin, if you're finding that the fasting glucose levels are reasonably well controlled and they have significant postprandial hyperglycemia, then this combination comes in as a good choice.
And very commonly, many doctors have asked it, sir. Can this be combined with, or there can be co-authored with the sulfonylureas, and how does it differ from glimepiride?
Yeah. So what we are saying is that since this works on the beta cells only, and it works in a mechanism which is not very different from the sulfonylureas, it works on a similar mechanism. It has got a faster onset of action. It works at a I mean causes faster release of insulin. So it doesn't I mean sound to reason to combine this with this SU. So this molecule doesn't go well with the SU, whereas it could go well with DPP4 inhibitors. It can go well with metformin. The combination can go well with probably GLP-1 RA, or it could go with even with insulin when patients who require insulin. So and still tend to have fasting hyperglycemia, or with the basal insulin it can go very well. So in with all these molecules it can go well, but with SU we would not like to combine this.
Okay, sir. Dr. Kamal has asked one question. There is a patient of 80 with a bypass many years back, and again angioplasty probably is done 3 years. Reading that question. So, because of angina, can repaglinide be given? Is it is it safe to give repaglinide?
Yeah. So in such patients, our concern is whether we induce hypoglycemia. If hypoglycemia is happening, then that may be a problem. If that patient is on SU, a long-acting SU, particularly if we use on glimepiride or even with the glibenclamide. So in such situations, you would like to give him a good agent which can bring down these postprandial glucose levels, because postprandial glucose levels, as we know, cause progression of the CAD, can cause worsening of the cardiovascular disease, and so addressing that is important. So in a patient like that, if he's on a sulfonylurea and having hypoglycemia, then shifting to this is very good. Now the other thing is that in the light of the recent evidence that is available, and in terms of the use of SGLT2 inhibitors and GLP-1 RA, that can be a good choice. But even after using them, what happens is many of them may not be under good control. The adequate control may not be achieved with the use of SGLT2 inhibitor only. So there, if you want additional therapy, then you can add this agent that can become a good addition, because it has a low risk of hypoglycemia, it addresses the postprandial hyperglycemia, and it can be a good add-on to the SGLT2 inhibitors in people like this.
Sir, is there any chances of GI adverse events? Can these GI symptoms?
Yeah, GI symptoms are known to occur with Voglibose, as we discussed. And what we were discussing was that the GI symptoms that occur are generally bloating and diarrhea and, and a little bit of belching and all that. So that gets tolerated better or reduced once you start with a small dose and gradually increase the dose. You can start with 0.2 mg and give it only once a day, then make it twice, then make it thrice, and like that you can increase it gradually, and the patient will be able to tolerate better. So that's the way it is to be given to reduce the GI intolerability. And the second issue is that what has been seen is that in some of the studies which have looked at the GI effects, that is flatulence and production of hydrogen gas and all that. Some of the studies done with the carbos have shown that there is a favorable effect on the gut microbiota also, and that can actually reduce inflammation also. So the GI side effects may not be all that bad. They may actually be, although they may be causing little disturbance to the person, but they may be causing benefit for the cardiovascular disease.
Then two, three doctors have asked, like if the HbA1c is controlled, so is there any requirement of adding this particular combination?
No, I didn't get the question. You said if the
Sir,
HbA1.
if the PPG, probably early A1C level of not so high, if it's well controlled with the probably Voglibose alone, is there any requirement to add Repaglinide plus Voglibose combination in such patients?
No, that is particularly helpful when the PPG is, I mean, HbA1c is high. So if the HbA1c has come towards 7.4, 7.5, you're not reached less than 7 or less than 6.5, you're planning in a particular individual young person who has got diabetes for a short duration of time, you're looking at 6.5. Or in an older individual also 7 is your target, and you reach say 7.4, 7.5. And there you can add this combination. If one agent is being used, you can add the other one also.
The other questions, again, there are two, three doctors have asked. What about with the insulin? Probably reduce the dose of insulin with
Your
this.
voice is not coming out very clear. Can you be a little
Yes,
louder?
sir. How about using this combination along with the insulin? Does it help in reducing the dose of insulin?
Yeah, along with insulin, as we said, what happens is that you may be using a premixed insulin. Sometimes you may be using premixed insulin. It doesn't give a very physiological coverage, and in spite of using the insulin twice, you may still be having postprandial hyperglycemia at the lunchtime when there is no insulin given at that time. Or there may also be situations where in spite of the fasting glucose being controlled, there is a postprandial hyperglycemia. In such situations, you can add this. You can reduce the dose of insulin. You can reduce the risk of hypoglycemia, and you can control the postprandial glucose effectively by addition of this molecule.
So one more question, that's Repaglinide secretagogue. So can it cause some weight gain?
Yeah, weight gain is likely to happen because it's a secretagogue. It can cause weight gain, particularly in patients who are lean and thin, who have lost weight, can cause weight gain. But again, having said that, I would say that the weight gain is lesser as compared to the SUs which have a longer duration of action. So
Yes,
here,
yes.
because of its short duration action, the insulin secretion being augmented for a shorter period of time, it has a lesser propensity to cause weight gain. Weight gain generally happens after, I mean, one of the components, there are two components of the weight gain we can say. One is because the insulin increase in insulin secretion, and another one is because of a inappropriately high insulin level for a longer period of time, say maybe 3-4 hours after the meal. That's when the insulin level should not be high. And with a SU, they may be persisting to be high during that period also. So patient will have a defensive eating at that time, and that can cause weight gain. Whereas this molecule, because it just increases the insulin secretion just in the postprandial phase for about 1 to 2 hours, and then its action is gone. So it causes less of weight gain.
Okay.
But weight gain is a factor which is there. It is lesser than what happens with SUs, and it is much lesser than what happens with other agents like insulin itself.
So another question from Dr. Sanjay Agarwal. What could be the maximum dose of repaglinide that can be given?
Yeah, I think the maximum dose that we can give is about 4 to 6 milligrams is the maximum dose that can be given. So we have 0.5 milligrams that we use 0.5 3 times, going up to about 1 milligram also 3 times. It can go up to 2 milligram 3 times is the maximum that we can go up to. Beyond that, it doesn't cause any benefit. It may not. It may actually cause more harm than benefit.
Okay. Any chances of morning hypoglycemia with this particular dose?
Yeah, I mean, the chance of morning hypoglycemia is much lesser, because what we are saying is that both these agents work for a shorter period of time. They've got just 1 to 2 hours of action, and because of that, they were not. They are less likely to cause morning hypoglycemia. They may cause hypoglycemia even when taken in the night. If they cause hypoglycemia, the hypoglycemia will be in the early period of the night. That is at midnight, around midnight or so, is when you expect the hypoglycemia. Whereas with SUs and with insulin, longer-acting insulin, you'll expect the hypoglycemia to occur early in the morning, 3-4 a.m. You may expect the hypoglycemia. With this, if hypoglycemia occurs, it can be at about 11 or 12 in the night. You are seeing that early part of the night, you'll see hypoglycemia with this, if it is happening. So that you can understand what is causing. If you're using, say, insulin and this agent, basal insulin plus this, then you can understand which is the one which needs to be adjusted, which is the one which could be causing the hypoglycemia, by understanding the timing of hypoglycemia.
Again, a question from Dr. Sanjeev. Is there any effect on the lipid profile? Any beneficial effect on the
Yeah.
lipid profile?
So if you look at, I mean, I didn't show any data on that in this presentation today, but if you look at the effects of Voglibose on lipid profile, we see that it has got a favorable effect on the triglycerides, and there's a reduction in triglycerides, and a very marginal change in the HDL, and some improvement in the LDL. The major effect is on the triglycerides, and Repaglinide doesn't have much of an effect on the lipids. It doesn't have a very remarkable effect, but the effect is because of the Voglibose, and the Voglibose has a major effect on the triglycerides.
Many doctors have complimented for an excellent presentation. Excellent, sir. Very informative. Many have complimented, sir.
Thank you.
Audience from the audience.
Thank you. Thank you for your patience and for hearing to the lecture.
I think the questions are actually the repeated questions are there.
So I think if we have completed, we have finished our time also.
I think so, sir, because most of the things you have already covered in the presentation. Same things have come up like pharmacology of Voglibose, dose and all, which you have covered very well. So I don't think so any.
So once again, thanks to all the audience who have joined in today, all the doctors who have joined in today and spent their time today evening with us, and we are very happy for having given for Ajanta Pharma for arranging this program also. Thank you.
Pankaj, you can close.
So,
Pankaj.
sir, on behalf of Ajanta Pharma, I would like to give my sincere thanks to Dr. Sahay for his deliberation, excellent deliberation. He is a lexicon of knowledge on this subject. We got few spark today. My sincere thanks to all the doctor who has attended today's webinar. because they have taken out their valuable time and they have joined today's webinar. Sir, all you know that Ajanta Pharma is a very serious player as per cardiology and diabetology is concerned. We have come with many new concepts like Atorfit CV. So these Volga are also need your help and support. And in future also, whenever new things will come, we'll definitely create certain audience and speaker interaction so that this will amalgamate very well and it will help all to grow on behalf of Ajanta Farm. Thank you very much, sir,
Thank you.
for your
Thank you, sir.
delivery. Thank you, sir.
Thank you very much.